Hello, everybody. Welcome to the health chat at Nanavati Super Specialty Hospital. My name is Sadhguru Pandit, and today we have with us Dr. Snehal Shah. Hello, Dr. Shah.
Hi, good evening.
Dr. Shah is MS ENT and MCH head and neck surgery. He has got an experience of over 7 years. And as you must have guessed, today's topic of discussion is head and neck surgery, head and neck cancers. So, Dr. Shah, to start with, you can tell us about head and neck cancers and what type of cancers are included in head and neck surgery.
So, if you see head and neck cancers, they have large number of subsites, starting from the oral cavity, starting from the lip itself to tongue to buccal mucosa, that is the cheeks to the tongue to the floor of the mouth to the bone mandible, the jaw cancers, the upper jaw cancer, the lower jaw cancer. It also includes palatal cancers, hard metal cancer. That is just for an oral cavity subsite. If you go beyond that, we come to oropharynx. Oropharynx will include tonsils, will include the posterior wall of the pharynx. It also includes, if you go superiorly, higher up, it is a nasopharynx, nasal cavity cancers, sinus cancers. If you go down, it will also include a hypopharyngeal, that is a food pipe cancer. It will also include airway, laryngeal cancers. So huge number of subsites. Not just that, but we also have something called as thyroid cancer, which are quite commonly seen. We have parotid, salivary gland cancers. So large number of subsites is what contributes to head and neck.
Okay, okay. And so, if you can tell us about the risk factors and most importantly, the most debated topic, how tobacco plays a very vital role in head and neck cancer.
So I would divide the, if you say, etiology for head and neck cancers into those which are confined to oral cavity and those which are non-oral cavity, or what I would say with tobacco and non-tobacco. Now, tobacco will cause cancers of the oral cavity, oropharyngeal cavity, nasopharyngeal cavity, sometimes maxillary sinus cavity tumors, larynx, airway cancers, food pipe, esophageal cancers. Now, these are the ones which are due to tobacco, maybe because of smoke, or smoked tobacco or smokeless tobacco. A smokeless tobacco is a chewed tobacco. Chewed tobacco is normally eaten with areca nut or tobacco in its finest form, and this can cause cancers directly. Not only does the tobacco have a nicotine, but apart from that, it has various other aromatic amines, hydrocarbons, so a lot of other chemicals which also contribute to the carcinogenesis. Now, not just smoking or a non-smoke chewed tobacco which can cause cancer, but it is also an alcohol which can also cause a cancer. In fact, tobacco and alcohol, they work in synergism. They work hands in glove, and the risk of malignancy goes eightfold higher if you have both tobacco and alcohol intake in a particular patient. But just not that, it can also happen because of genetic changes. That's why we also have in few patients the family history of oral cancers, oropharyngeal cancers. Apart from that, we have certain viruses which can cause cancers. This include human papillomavirus, which is quite common nowadays. Apart from that, we also have cancers due to Epstein-Barr virus (EBV), which can cause a cancer in the area which is behind the nose, just posterior or behind the nasal cavity is what we can see those cancers. Apart from that, those patients or those people who are working in industries, something like exposed to tar industry, or charcoal, nickel, cadmium, all of them who are exposed to those chemical carcinogens can also have a cancer of a nasal cavity. A nasopharyngeal cancers can also be seen in those kind of patients. So smoked tobacco will predispose to oral cavity, laryngeal cancers, and cancers of lung. While the chewed tobacco will predominantly cause cancers of the oral cavity, of the oropharynx, of the hypopharynx, and of the esophagus. That's the food pipe cancers. Now, this is for the tobacco. If you see for thyroid cancers, then that could be genetic predispositions, or it could be exposure to ionizing radiations. Now, this can cause not only a thyroid cancers, but they can also cause parotid cancers. Parotid cancers are also known to occur secondary to ionizing radiation, and patients can have this kind of malignancy. So, not just tobacco, but also exposure to ionizing radiation and the other gamut of risk factors which are responsible for causing the head and neck cancers.
Right. Any other environmental factors that you must have, as in pollution or diet, is that also matters?
So diet. Sometimes they say that the intake of a salted fish, say nitrosamines, which are present in the salted fish, can cause cancers of nasal cavity, nasopharynx. Apart from that, it is said that a spicy food can sometimes cause oral cancers, but they are not proved. So yes, dietary factors are responsible, but for not for all the subsites, maybe for certain subsites that you can say as nasal cavity, nasopharynx.
Right, right. Thanks a lot, doctor. Also, have you seen any disparity in terms of how it affects men and women?
If you see our socio-economic status of the society, there are men who are going to eat or use tobacco more than a females, and hence males by and large are predisposed to more cancers than females. All said and done, even female, there is a rising incidence of females smoking, using tobacco, and yes, the risk factors are almost same for both. But if you see the prevalence is more for males than for females.
Right. Thank you, sir. Also, you briefly spoke about the family history of cancer. So, how big a role does that play?
So I would say that familial incidence of head and neck cancers is rarer. They are more common. They may be more common for thyroid cancers rather than for oral cavity or other subsites cancers. But yes, there are few syndromes which are associated, which a patient can have, and which can predispose them to this kind of cancers. Syndrome is a group of three or more abnormalities that patient can have. It is mainly a genetic, and this can lead to cancers. So a rarer incidence, but yes, it is significant.
Okay, thank you, sir. And if you can tell us about the symptoms, because patients, of course, the early detection is something that we always stress on. So, what are the symptoms that people should look out for when we want to catch oral or head and neck cancers early?
So we always advise patients to examine their oral cavities, that is, examine the mouth by their own, preferably on everyday basis, because there are certain potentially malignant conditions which can predispose to the cancer. The most common of them is having a red patch or a white patch. A white patch is called leukoplakia. A red patch is called as erythroplakia, or a white and a red patch is called as erythroleukoplakia, or other condition like submucous fibrosis. These are some of the potentially malignant conditions which can predispose to the carcinosis. So mouth self-examination is, I would say, is one of the most critical aspect, especially for those who have been using tobacco and alcohol. They should examine. Ideally, they should cease taking tobacco, but they should always have an eye on their oral cavity. Examine their oral cavity by themselves every day. Look out for these patches. If they have this kind of patches, they should report early to the physician. Probably the cancers in the early stage could be picked up. So yes, uh, mouth self-examination is most important, and there are these other conditions. Sometimes they can have a non-healing ulcer. A non-healing ulcer, say for more than 3 weeks or 4 weeks, could be a malignant ulcer, and this again should ring the bell, alarm bell. They should report to the physicians. Apart from that, they can have a node in the neck, a neck swelling, which could be of a cancer. So yes, apart from potentially malignant disorders, neck nodes, non-healing ulcers are few situations which symptoms and signs that we should look out for that this could be potentially a cancer. Apart from that, for those cancers of airway or for those cancers of esophagus food pipe, there could be difficulty in breathing, or there could be difficulty in deglutting, that is eating, swallowing the food. Now, if these are the situations, then yes, there is high probability that patient might be harboring a malignancy.
Right. So, doctor, the nodes you spoke about, do they have to be painful, or because people only worry about the painful nodes?
Yeah, so they are by and large of painless nodes unless and until the node is involving the skin, which is overlying it, or if it is going to involve a surrounding structures like some critical structures in and around the neck, they can become symptomatic. So by and large, our painless neck nodes are the ones which you which the patient can present to you. About 80 to 90% of the patients will present with this kind of presentation, and about 10 to 15% will present with advanced neck node disease.
Right. So you spoke about the symptoms, but have you what is the kind of awareness that you think people have amongst your patients also when you see them? Are they coming early for detection, and what are the causes that they give for delaying detection?
So in India, we see about 75% of times that 75 times out of 100, we see that patients come in an advanced stage. They don't come in the early stage. Probably there is some amount of ignorance, there is some amount of negligence as well towards their self care, and that's how they come late. Probably there could be some economic factor as well, that they would take some time to come, and there would be some delay. So by and large, advanced cases that we see, 75% of the cases are advanced, 25% are early.
Right. And what are the reasons that they give for not going to the hospital on time?
First of all, they are not aware there has been a cancer, there has been a growth. They do refer to a local physicians who might not be aware of this being a cancer. But now, with the awareness that I'm seeing, the general physicians are diagnosing it quite early, but still the presentation to them itself is in an advanced stage.
Right.
So there we need to create a lot of awareness amongst the general population as to what are the signs symptoms of cancer and how they should be alert, vigilant enough to pick up those cancers, those sign symptoms, and come back.
Right. Also to visit a specialist oncosurgeon or
Absolutely,
oncologist.
absolutely. For them, they if they have any suspicion, they should come and visit an oncologist. We at Nanavati are always there, available for them, and yes, we would take care of them.
Right. Thanks a lot, doctor. So you spoke about detection. Can you tell us about the screening part and how exactly do we screen these different types of head and neck cancers?
So, coming again to the tobacco-induced cancers, screening can be done, as I said previously as well,
Yeah.
that we do a mouth self-examination. But yes, getting screened for the oral cavities by the dentist as their what I would say is the first contact, as the first contact, could also help in diagnosing early cancers. We have got trials done in India, where it has been a general, just a light examination, just a bright light examination, where health workers who are just 12th pass, they've gone around in the community, and they have been initially they have been made aware about what are the 5 to 6 signs and symptoms of oral cancer, say a white patch, a red patch. And believe me, this is a study which has taken place at Kerala by Dr. Satyanarayana. And what he found out is that they could detect early cancers, cancer, cancer mortality due to tobacco was reduced up to 39%.
That's great.
We have a trial going on still at Tata Memorial Hospital as well, where we are looking at in some small districts which have got a higher incidence of tobacco usage, where this trial is still going on, just to see whether bright light examination is effective or not. But apart from that, this is something which is going on, which probably could be cost effective. But apart from that, we have other modalities as well, say application of toluidine blue, or say we have something called as a Raman spectroscope or a well scope. There are various modalities which are available which help in raising the alarm bells for a lesion being suspicious for cancer.
Correct.
May not prove it, but yes, there are various modalities available, but none of them have been proved that cost effective. They've got their own pros and cons.
Correct.
In the research. Coming to thyroid cancers, yes, we don't have anything as of now in India, but Japan and all, Korea, South Korea, Japan, they started their trial. Even US, they started trial in screening for thyroid cancers. They started doing ultrasounds. They started picking up a small nodules, early thyroid cancers. For them, they found it to be quite cost effective. Maybe that model could be effective in India, but it's not proved. We have not started yet with any of these trials.
Right. So there are in fact models which have proved that even in large
Yes.
population bases like India, we can have some training and early detection of cancer.
Of course, for stress on oral cavity cancers, where even the 12th pass health workers, trained health workers, can go to the community. May not require the dentist to be around, but yes, we can have health workers who can go do a oral examination, mouth examination, pick up the lesions, raise suspicion, and refer them to dentist or to the oncologist.
Right. Also, you mentioned while you were discussing about the part of the dentist. So, I know this is something that people don't think of, but how important is your routine dental examination, which I don't think anybody or most of people do in India. But how important are they in picking up these early signs, and what is the percentage approximately of your cases which are coming from these guys from the dentist who pick up the early signs of cancer?
So to be honest, till date, the first contact for the patient is still a general physician who will do a head to toe examination. But yes, on an average, a private dental practitioner would pick up at least 5 to 10 cases in a year.
Okay.
So that is again still quite a significant number. They can have 10 to 15 uh, you know, patients who they pick up for the cancers and they can refer to us. So still the numbers are less, but yes, they are rising.
Right.
With
So
increasing
routine,
awareness.
correct. So routine dental examination also plays a vital role in picking up the
Absolutely,
cancer.
absolutely.
Right, right. Thank you, sir. So talking about the stages, how do you determine at what stage of advancement is the cancer when it comes to head and neck?
So, coming to my focus will still be on oral cancers, which is quite common as compared to thyroid cancers.
Right.
And if you see oral cancers, or for that matter, oropharyngeal cancers, any tobacco-induced cancers, there are 4 stages. Stage 1, stage 2 are the early cancers. Stage 3, stage 4 are the advanced cancers. Whenever the cancer involves skin, it involves bone, or it crosses more than one compartment, it becomes an advanced cancer. Whenever by and large the cancer is confined to one compartment, they could be early cancers. Now, advanced cancers, if you see, are the ones which will also have more symptoms. Patients will come with more symptoms and signs. They'll have a lot of neuralgic pain. They would have ulceration of skin, a tumor coming out of the bone, tumor coming out of the skin. So these are some of this is how we divide arbitrarily the oral cancers, or for that matter, any head and neck cancer, into 4 different stages.
Okay. And is head and neck cancer, does it advance really fast, doctor, as compared to other cancers, say breast or cervical or any other cancers which are most common in India?
So the question is quite dicey.
Yeah.
For the only reason that you cannot predict the biology of a cancer.
Okay.
For everyone. It's like every individual will have a tumor biology which is different from other. In some, it may be aggressive. In some, it might not. Now, there are various factors on pathology, which if I go into is too extensive, but there are certain bad features and there are certain good features. Many of the patients will have these bad features, and you will have cancers recurring, cancers coming aggressively. You're not able to give disease survival better than others, just because no matter how good you give the clearance, just because of the aggressive tumor biology. If you compare head and neck cancers with other cancers of say breast or say liver or lung cancers, I would say that survival in head and neck cancer is any day better as compared to lung cancers, as compared to brain cancers, as compared to your GI cancers, pancreatic cancers. They all do worse as compared to head and neck cancers. In head and neck cancer, even if the disease is advanced, at least 50%, 25 to 50% will be survival. This number is quite less in lung cancers, or for that matter, liver cancers, or for that matter, even brain cancers or GI cancers. So head and neck stands in a good position that way.
Right. That was actually my next question about the prognosis. of and the survival rate of head and neck cancers in terms of stages.
So stage four, if I say, I'll come to stage four. Stage four is divided into three stages: 4A, 4B, 4C. 4C is when the disease has gone beyond the head and neck and has gone into lungs, to the bone, to the brain. Now, those are the only subgroup of subpopulation which won't do well. Even stage 4B is treatable, and even then the survival is up to 25%. So yes, if you compare this with the stage 4 of lung cancers, liver cancers, they do far worse. So even at stage 4B, a stage before inoperability, unresectability, I would say these are the patients who would do well. Many of them would do well as compared to other subsites. So prognosis is definitely better than other subsites.
That's great, and I think it's a positive message, encouraging for patients who have unfortunately recently they must have been detected that they don't need to stop going ahead and getting the treatment. Their survival
Absolutely,
is
absolutely. They should go ahead and they should get treated. They stand a good chance of cure.
right, right. Thanks a lot, doctor. Also talking about the treatment part now. If you can tell us, because it is difficult for laymen to understand when do we give chemo, when do we do surgery. So do all of them need surgery or all of them need chemo or radiation? If you can tell us in simple, about the line of treatment and how does it go?
So, for head and neck cancers, we again divide this into early stage and a late stage. Early stage cancers will be treated well with only single modality. Now, what are the modalities available? The first is surgery, second is radiation, and third is chemotherapy. For early stage cancers, surgery or radiotherapy would suffice. They don't have to undergo adjuvant or add on radiation or add on surgery unless and until the tumor biology is bad and the disease recurs back, otherwise not required. For advanced stage, that is stage 3 and stage 4, you would require surgery followed by radiation or chemoradiation. But there are certain subsites like oropharynx, like nasopharynx, that is the area behind the nose or the area behind the oral cavity. Those are the areas where surgery in an early stage is possible, but they have an advanced neck disease by and large. Now, these are the places where you might not offer, say, a surgery, but you would like to go ahead with just a radiation, or early stage radiation, only radiation, or late stage, advanced stage, you might like to give a neoadjuvant chemotherapy followed by a chemo radiation or only chemo radiation, and offer a salvage surgery if there is a residual disease or a recurrent disease left behind. So yes, early stage is single modality, advanced stage is double or triple modality treatment.
Right. Thank you, doctor. Also, next question was, we see a lot of these advertisements on television about oral cancers, and I'm sure it spooks a lot of people out who might think that after you will be scarred for life, visually after an oral cancer surgery or head and neck surgery. If you can tell us about how do people fare, after, do they have the quality of life? Is there any permanent cosmetic damage that happens after a head and neck surgery?
So to be very precise, this is for a general population that we're having a
Yes.
talk. So the message to them is that what God has given, you would never get it back.
Correct.
Because we are trying to resect, remove an organ which is harboring a cancer. But in today's times, with plastic surgeons doing a lot of onco reconstruction, yes, we are able to reconstruct huge defects. We are fairly able to give a good quality of life. We are fairly able to provide a good functional outcomes. Not just reconstruction. After radiotherapy, we also send this or refer these patients to a speech and a swallow therapist. We send these patients to a occupational therapist for a jaw stretching. We send them to a physiotherapist. So we try and improve. We try and I would say augment their rehab. So we do a lot of things which go a long way. We have this head and neck cancers. We have a huge team. It's just not consisting of a surgeon, a radiation oncologist, a medical oncologist, but equally important are the people who are working behind us or with us rather, not behind us, with us, hands in glove, are the ones who are physiotherapists, who are occupational therapists. We have dentists who also play. We have prosthodontists who also play an important role in making the patient stand on his feet and trying to make patient as acceptable to the society as possible.
Right. So it's important for patients or people also to understand that head and neck cancer is not just a department at Nanavati. It's a holistic effort by different specialties which comes together.
We need a huge team.
Yeah.
We have all the specialties. We have all the facets for rehab. We do rehab on daily basis.
Right. So speaking of quality of life, because we talked about the speech and swallow and occupational therapists working on patients, do all patients need them, or do all patients post surgery have sensory deprivation, or they have problem in swallowing or speaking?
So advance, bigger the disease, larger the disease, advance the disease, more is the morbidity, more are the people who require. Early stage diseases may not have so many morbidities. They might do well without the help of our other team members. But yes, advanced do require. They do require, and that's why the emphasis is pick up the disease at early stage. Come at the early stage, minimal morbidity, maximum function.
Right. And do early stages retain all their normal functions?
Absolutely, absolutely, because the amount of tissue that is involved with cancer is less. So the resection that we do, which is about 5 millimeter to 1 centimeter margin all around the tumor, that also is less. And since lesser amount of organ is cut, that organ works well.
Right. Thank you, doctor. Lastly, technology has been playing a vital role in many areas, many medical fields. Is there any technology that you are expecting or you think would change the how you're managing head and neck cancers?
So we at Nanavati have started practicing a lot of endoscopic head and neck procedures. We are trying to build up our expertise for endoscopic thyroids, where we can do with just a small incision, minimal access. We'll just give a small incision and get thyroid out. We're also developing our robotic program for head and neck, where we're trying to remove small early cancers of the lesions of the cancers which are in the behind aspect or posterior part of the oral cavity, say oropharynx, that is, say at the tonsil, a tonsillar cancers, say cancers on the base of the tongue, or say a cancer at on the larynx, on the voice box. A small cancers, we are trying to do them without giving any scar to the patient. So yes, with the evolving technology, we are also evolving. We have also got into a robotics for head and neck and endoscopic for head and neck. Apart from that, being a surgeon, I would always speak that. But then, if you see from a radiation point of view as well, you have various technologies like IMRT and IGRT. These are the technologies which will reduce the side effects of the radiation. So those have come into the action since last 10 to 15 years, and we have been doing that at Nanavati. So yes, with newer technology innovations, we are offering the patients minimal access, small scar surgeries, and trying to get out the disease.
Right. Thanks a lot, doctor. Now we'll take some of the questions from our viewers which have come in.
Sure.
So Arushi Dixit is asking what clinical trials are available for head and neck cancers, and how can she find out more about them? Is there any one?
So lots of trials in head and neck cancer, lots of trials. So you can go on a site called as clinicaltrials.gov.in.
Okay.
It's a international based trial, and you would have trials from all over the world, which you'll find the mention of all of them.
Right.
All the trials related to head and neck, just not head and neck. Any other subset in the body, you'll have lots of trials. You'll have go to clinicaltrials.gov.in and you'll get it.
Right. So Arushi will respond to you in your Facebook comment section so that you will get the link where you need to visit. So Priya Singh is next. She's asking what are the possible side effects of the treatment both in short-term and long-term head and neck cancers?
So, if you see surgery, you will have early stage, you won't have much complications, you won't have much morbidity. But if you have advanced tongue cancer, for example, where you land up removing huge amount of tongue, now these are the patients who will find difficult to swallow, to speak. But with speech and swallow therapy programs that we run, the chances of their recovering are quite high. Many of them are dependent on an air pipe. Air pipe. We put a tracheostomy tube, so they are dependent on a food pipe, or what we say is a Riles tube or tracheostomy tube. So we try aggressively for those patients, try and give them rehab, so they do away from this dependency.
Correct.
So complications are there of surgery, especially for advanced, but surgery is a way to cure. So if you have to undergo surgery, you must undergo, because the rehab that we give you will improve your outcomes to at least 70 to 80% of what you were leading. The life that you were leading before, we can give you at least up to 70 to 80%.
Definitely.
So please go ahead. Secondly, if you see radiation, then here's a lot of side effects like xerostomia, that is uh, dryness of the mouth, or for that matter, you can have mucositis, that is developing a mouth ulcers, or you can have a long-term complication of fibrosis. The quality of the skin, the elasticity of skin undergoes a change because of the radiation. But yes, with a good physiotherapy, even this improves. We are doing IMRT, we are doing IGRT, and we expect the complications to go down.
Right, right, sure. Sorry. Meenakshi Chaudhary is asking, how will this treatment affect my daily life? Will I be able to work and perform my daily routine after the surgery?
Absolutely. That's why surgery and that's why a rehab team. You should go ahead with your normal life. We'll try and bring your life to normal if you are a patient, as close to the normal as possible. May not be total because this is a cancer surgery, but yes, we can. Lots of hope and lots of optimism. Go ahead.
Right. Uh, Niku Srivastav is asking, what can be done to prevent or manage the side effects?
To prevent, we have various technologies available. To manage, again, as you go ahead with your treatment, lot of ancillary aids are given to you. We have for jaw stretching exercise. We have, if the patient undergone a surgery for a mouth oral cancers, followed by radiation, mouth opening is going to get affected. So to treat or to improve that, we do give you a jaw stretching exercises. We teach you jaw stretching. There's going to be some shoulder mobility. We are trying to give you a lot of shoulder for the neck. We are try and bring about a suppleness in the neck. So yes, there are various ancillary aids available. We can use all of them and try to bring it to.
Correct. And of course, the most important one is to make sure you don't get it.
Yep,
So, avoid all the preventable causes of cancer, and then you don't have to worry about the side effects.
avoid tobacco and alcohol.
Yes. Nikita Singh is asking, sir, will I need to undergo reconstruction surgery to replace the lost tissues?
Yes, for advanced cancers, not for early cancers. Early cancers you will do well. You may not require any reconstruction.
Right. Renu Singh is asking, what are the current guidelines for extent of neck dissection in oropharyngeal cancer? Is level 1B dissection mandatory?
So I would say if it is a tonsil cancers, tonsillar cancers, uh, you would undergo a comprehensive neck dissection. If it is lower down, say a larynx and hypopharynx, you would restrict yourself from level 2 to level 5. You would not do level 1B. Level 1B is done only for oropharyngeal cancers, 1 to 5 for oropharyngeal cancers, 2 to 5 for laryngeal cancers, hypopharyngeal cancers.
Right. So Ionija Das is asking, is head and neck cancer painful?
All cancers are painful, all treatments are painful, but if you need to have a cure,
Yeah.
you should undergo a treatment. Initially they are painful, eventually they would pay you rich dividends.
Okay. And so Namita Das is asking, how can I detect neck cancer?
So I would like to know that is she a medico or a non-medico?
Okay.
Because the only thing is you can just palpate your neck.
Okay.
Nothing else.
And look
If
for
you
the
have
notes.
if you have any symptom, look for notes. If you have any symptom like, or if you have any symptom like there's difficulty of eating, swallowing, there's difficulty in swallowing the food, or if there's difficulty breathing, you can report. You can go to an oncologist. You can get your scans done. You can get a physical examination, and maybe he can diagnose for you.
Right. Thanks a lot, sir. Any last message that you would like to give our viewers about the head and neck cancer?
Please go to the treatment of head and neck cancers. Believe me, the survival is much more. Hope is big. So do not let it go down. Come to us, we'll help you out with whatever possible.
Thanks a lot, sir. Thank you. I'm sure it was an informative and insightful talk for all the viewers.
Thank you.
And stay tuned, guys. Yesterday, as you know, February 4th was the World Cancer Day. So keep talking about cancer as much as you can to your loved ones, to your acquaintances, friends, family, and go for early detection. Go for any symptoms that you see. The first chance that you get, you go and visit your doctor, a physician, an oncologist, and make sure the loop is closed. You don't just leave the symptom lying there. Just make sure that you find out a reason for it, and you see doctor like Dr. Snehal Shah sitting here right here to help you out. So thanks a lot everybody for watching the health chat, and we'll be back next time with a different topic. Thanks a lot.
Thank you so much.